Good afternoon, everybody. Welcome to Live Research Forum, Talents of Tomorrow. I'm Professor Supatpon Thepmongkol, Assistant Dean for Research Affairs, Faculty of Medicine, Chulalongkorn University. First of all, I'd like to introduce to you our distinguished speaker today. Professor Stephen Kerr is a Director of Biostatistics Excellence Center in the Faculty of Medicine and the Head of Biostatistics at HIFNet, the Thai Red Cross AIDS Research Center. He worked for 8 years as a clinical pharmacist, then completed a PhD in neuroscience before eventually studying international public health and biostatistics. He has previously worked at many world-renowned institutions like Brigham and Women's Hospital, the Australian National Prescribing Service, and the Kirby Institute. He came to Thailand in 2003 and worked on a series of antiretroviral strategy and dose optimization trials. He helped build biostatistical capacity at HIFNet, which has for the last 5 years been a clinical trial site for NIH USA. He also helped Faculty of Medicine to build biostatistical capacity. He has more than 200 publications and he has very high H index. He is a statistical reviewer for The Lancet and on the editorial board of PLOS Global Public Health. Today, he will tell us about a new and currently in trend quasi-experimental design of how it can help us help your research. And I think we are eager to know if it can be used as an alternative to RCT or not. So today, he will deliver to us a topic of quasi-experimental design as an alternative to RCT. So please, Professor Kerr.
Thank you very much, Ajahn Supatpon. I'll just get my screen sharing organized and the presentation. Okay. So I wanted to talk about quasi-experimental designs because a lot of the time when people come to see me, especially fellows, they're interested in doing an RCT, but often the time period that it's possible for them to actually do an RCT during the period of their fellowship is very limited. So I wanted us to explore some other options. Doug Altman, who was one of the most fantastic biostatisticians who died actually just last year, but he was really instrumental in putting together all of the reporting guidelines and had a great column in the BMJ for a long time about helping people to understand statistics. But in 1994, he published an editorial and he just pointed out that huge sums of money are spent on research, but the research is flawed because of inappropriate design, small samples, incorrect analysis and faulty interpretation. And one of the things he blamed on was that the system encourages poor research. And one of the reasons is because we base our criteria for promotion on number of publications. And he basically said we need less research, better research, and research done for the right reasons. Then 20 years later, in another editorial, the BMJ editor at the time, Richard Smith, basically said 20 years later, I feel that things are not better but worse. And then we just had another editorial in the beginning of July in the BMJ talking about fraudulent research. Fortunately, I haven't ever encountered any fraudulent research, but some of the data that they talked about and the journals that had been publishing these studies, it was very disturbing. And I think it has implications for public health and implications for taking care of our patients. So we've all been taught for years and years that, and we've all seen that pyramid, that after systematic reviews and meta-analyses, RCTs give the highest level of evidence. And that's true, but it's only true if you enroll enough people and assign people to groups with a random allocation sequence. And if that happens, then the known and unknown confounding factors will be balanced across the groups. And it's the unknown ones that are very important as well as the known. And that allows us to make strong inferences between cause and effect of our intervention and get an unbiased effect estimate. But not all interventions can be assessed with an RCT. So if it's some intervention or if you're looking for an association between something harmful, you're not going to do that with an RCT. RCTs are also very labor intensive. They're expensive to run, especially if you've got multiple sites, you have to monitor, verify the data, everything has to comply with ICH GCP, and sample sizes are often too small because we assume an unrealistic effect size, mostly to allow someone to be able to finish a project in a short time. And RCTs also have questionable external validity. So even though the internal validity is very high, the generalizability to real world settings might be poor. So for example, if you look at the inclusion criteria for elderly patients in clinical trials, often patients with multi-morbidities are excluded. And we know that elderly patients have lots of multi-morbidities. Pragmatic trials can, to some extent, help us get over this, but they also have their own difficulties. So just a quick overview of experimental RCTs. They're kind of comparatively recent. James Lind in 1753 did an experiment on a ship to show that citrus fruit can prevent or treat scurvy. He had, I think he only had about 6 people in each group, but he wanted to ensure that each group was very as similar as possible in all the characteristics he could observe. And half of the participants he gave lemons or oranges, and the other half he gave seawater. And unsurprisingly, the ones who had seawater didn't get better. Fibiger did some additional work on diphtheria antitoxin, but the first real randomized clinical trial was only done in 1948, which was a trial of streptomycin versus bed rest for treatment of TB. And the researchers randomly allocated people to prevent the investigators from unconsciously or subconsciously selecting different types of patients for the treatment arms. Then after that, after that trial was done, we saw an explosion in RCTs. Big Pharma realized that it was a very important tool for them. And we saw lots of trials in cardiovascular disease, oncology, and HIV. So with the experimental study in the RCT, a researcher is intervening in the natural process to establish the causal effect of the treatment. But in a quasi-experimental study, the causal effects of a treatment are established without a researcher's intervention. So they offer opportunities for causal analysis in health research because they can generate results of high external and internal validity and can be used when experiments are not feasible. And even though, and the reasons they might not be feasible are financial, ethical, or political constraints, but they have been widely used in economics and social science for a long time. We just haven't used them in health. So these are some examples that I'm going to talk about today. So first of all, there's natural experiments. So a natural experiment can also be integrated into any of these other experiments. But a natural experiment might be something like there's a policy change implemented by the government that restricts access to some drug. And then researchers can study the outcomes before restriction and after the restriction of the drug. There's lots of other examples. We're going to talk about interrupted time series regression, which is sometimes called segmented time series regression. Regression discontinuity. We're going to talk about step wedge designs, differences in differences analyses, matching and reweighting methods. And there's also instrumental variables and extended regression models, which I'm not going to talk about today because they're kind of complicated. But the reason that I think all these techniques are important is that they can be used with administrative data or data that we're routinely collecting as part of our clinical work. So I think if there's hospital databases with laboratory data, patient history, lots of other stuff that we've got access to, that's a fantastic resource for residents and fellows to use to do research projects. Of course, there's caveats and assumptions for all of the models that we're going to talk about. And as the complexity of the model increases, so does the number of assumptions. But I don't think that should stop us worrying about them because there's complexity and assumptions in everything we do. The most important thing is that the researchers have a good knowledge of their topic so they can understand how to make the model and to model the potential confounders. And we'll see some examples of that. So interrupted time series. I'm going to give you a simple example. It's used to evaluate the effect of an intervention and is considered to be one of the strongest quasi-experimental designs. And you collect data at equally spaced time points, pre and post intervention. Could be weekly, it could be monthly. You need to have an adequate number of pre-intervention points so the trend is clear. So that if you're collecting, say if you're doing something and you're collecting monthly data, you'd want to have data for the last maybe 1.5 years so that you could tease out after you have an intervention, what's going to happen with the trend that was already in progress. And you also need to know when the intervention starts, which isn't difficult because we often are making the intervention ourselves. And you need an adequate number of post-intervention time points so you can calculate the post-intervention trend. Some of the assumptions are about autocorrelation, seasonality, and other interventions that might potentially affect the outcome that might be happening at the same time. So this was a study we did in Sydney in, I guess, 2017 to 2019. So the problem was that the problem in Sydney was the same as the problem in many other countries where old people were being prescribed oxycodone after they had surgery. They would leave hospital, their general practitioner would continue giving them oxycodone. They wouldn't be able to get off it, and there was a high mortality from opiate overdose. So we were looking at, this is the monthly oxycodone 5 milligram tablets dispensed per 100 surgical cases. And we can see data from 2005 up until June 2013. July 2013. And you can see that there's an increasing trend in the number of prescriptions. And at this point, we introduced some interventions, and they were very simple things like we would talk to the patients on admission about the importance of not continuing to take these pain medications. We'd send the residents on the wards data about their own prescribing, and they were just kind of soft interventions like that. And those were implemented in the month, in about August, I think it's so, August, September. And what we saw is a very small drop in the monthly numbers after the intervention, but then it kept going almost at about the same rate. So then we implemented another intervention here, which was basically one of the anesthetic attendings going to talk to every resident on the ward and telling them you have to assess the patient's pain, but you shouldn't send them home with too many oxycodone tablets. Make sure their pain's controlled before you send them home. And they continued doing that. She continued doing that every month, going and visiting every resident on all of the wards. And after that, we did see a decrease in the number of oxycodone prescriptions. And so we can see that there was the trend after the first intervention is not much change. The baseline trend was 1.8 in the numbers prescribed. We analysed it like this because I thought it was quite easy to interpret, but there's other really interesting ways you can do these analyses. So this one is called STL decomposition. I only did this up until the beginning of the first intervention or just after the first intervention. What it does is that this is the actual data, and it breaks the data down into a seasonal component, a trend, and then the remainder, which is not accounted for by the model, so the error term. And these bars here just show you the relative size of these graphs to each other. So what's particularly fascinating with these is we see this big drop here, and we see a few different drops. And it's this seasonal thing that happens with the opiate prescribing, because this is at Christmas, New Year, when the theatres are all closed for elective surgery. And this is at Easter. And then these are school holidays later in the year. So it's interesting to see how these things play out. But after you take away this seasonal component and subtract it from this, then you can see what the trend in the actual prescribing is. And so this doesn't have to be just done for drug prescribing. It could be done for lots of other topics, which if you're a specialist in your field, you'll be able to think of some examples. Now, another one is regression discontinuity. So regression discontinuity is useful when some exposure or treatment will be initiated at some threshold rule. And so we can estimate the causal effects by the regression discontinuity. So as an example, patients might be assigned to a particular treatment regimen if they're high risk based on a continuous biomarker. So maybe if they've got a very high cholesterol, they'll start them on a high potency statin. And because these continuous biomarkers are subject to random variability, we expect the patients just above the threshold the threshold affects the outcomes, we expect to see a discontinuity in the regression around the threshold. But if there's no treatment effect, then the regression line should be just continuous above it and below the threshold. A good example of this one was actually done using data that was generated by a trial, but it could also be done after the country initiated some rule about drug access, or we've used looking to see what impact changing the HIV treatment guidelines to initiate ART at any CD4 count, which was done in 2014. We looked to compare how long it took people to actually initiate treatment before that policy was introduced and after that policy was introduced, and then what impact that had on things like virological suppression and loss to follow-up from the program, which was data very kindly provided by the NHSO. This project was done on the prostate, lung, colorectal and ovarian cancer screening trial, which had a lot of people, 76,000 men, and they were randomized to annual prostate-specific antigen screening for 6 years and annual digital rectal examination for 4 years, or every 4 years. And a PSA level of 4 was used as a threshold for further workup. So if we look at some of the data, so here's some of the regression discontinuity analyses, and these are done with, so these are probability models, so they're logistic models. So the effect sizes are absolute changes in the probability above and below the threshold. And we see here for undergoing a biopsy, there was a big, physicians did get people to have a biopsy if the PSA was greater than 4. And so the absolute change in the probability of having a biopsy was 27%, with pretty tight confidence intervals. Low risk prostate cancer detection also increased by about 7.2%, an absolute change. Is that 7.2? Or that might be a bit more. I might have put the wrong number. But you can see it's about, looks like about 10% increase in the probability there. In the high risk cancer detection, there was no change. And in terms of mortality, there was also no change. So that's important. And that's important information to know that the PSA, maybe it increases your risk of having or increases your chance of having a biopsy, but the effect on mortality was actually very minimal. This is another study that used a regression discontinuity analysis, and it was based on a trial in South Africa that was doing early initiation of antiretroviral therapy or initiation of antiretroviral therapy when the CD4 count fell to below 200. And so what we saw here was that there's a discontinuity. The people who started when their CD4 count had got down to 200 instead of starting when they got an HIV positive diagnosis, their mortality rate increased compared to what would be predicted if they'd have started when they initiated ART, or when they got their diagnosis, sorry. Lots of examples of regression discontinuity analyses in the literature. Drinking age on mortality, drinking age on alcohol-related morbidity, effective air pollution on mortality, genetics on stress responses. And this is from an article about 5 years ago. So there's many, many more examples now in the literature. Okay, differences in differences is another one. So differences in differences uses longitudinal data from treatment and control groups to obtain an appropriate counterfactual, also the baseline scenario, to estimate a causal effect. It's typically used to estimate the effect of a specific intervention or a treatment by comparing the changes in outcomes over time between the treatment and the control groups. And one of the classic examples of differences in differences studies in medical research was John Snow when he was looking at the cholera epidemics in London. I think there were two rounds of epidemics. One was in about 1848 and the other one was about 1854, something like that. And in the first period, so there were two neighborhoods he was comparing. In the first period, the water companies supplying both of those neighborhoods got their water from the Thames in the middle of London. But before the second epidemic, one of the water companies that supplied the water to the other neighborhoods started getting their water from upstream. And so it wasn't contaminated by sewage and other things. And so Snow was able to infer that that there was something in the water that was causing the cholera. The way that this kind of study worked is that we've got two groups that we're following, and we kind of have these parallel trends in what's happening. And then after an intervention, the trend in one group changes. And this is the trend that we would expect if there'd been no intervention. And this is the difference in differences, and it can just be modeled as an interaction term in a regression model. And yes, there's some interesting studies in the literature. I just saw one from the US that was about air pollution and how clean air had been, or a Clean Air Act had been implemented and changed some of the respiratory outcomes. I'm definitely waiting for somebody to do a study on clean air in Chiang Mai during the period where there's a lot of pollution. There's some useful links about difference in differences study at this website. Okay, now matching and weighting, another technique that we can use, and I think everybody's heard of the propensity score. Okay. So there's lots of options in Starter for matching to estimate a treatment effect for outcomes that are conditionally independent on the treatment. And when I say conditionally independent on the treatment, I mean that the variables affecting treatment assignment and outcomes are observable. We can measure them. There may be some that are missing, but we know what they are. They're not endogenous. Treatment, these are some of the commands, treatment effects, and you can have continuous, binary, fractional, or count outcomes. There's ST effects, which also has many functional forms, but estimates difference in survival time. So it's a parametric survival model. There's TE lasso, which has all the functional forms that TE effects has, but with lasso methods or machine learning methods for covariate selection. DID regress for differences in differences regression, and XT DID regress for longitudinal data sets and differences in differences. Also lots of tools for checking covariant balance and summary statistics and diagnostics. So these are some of the methods that we can use for estimating treatment effects. Augmented inverse probability weighting. So I should have put these in a different order. So the one that we most commonly use is regression adjustment, where we just adjust the variables in our data set using, some rule that we decide. If it's significant at less than 0.1 in a univariable analysis, we're going to adjust for it. Unless it's a known confounder, then we're also going to adjust for it. Propensity score matching is something that we're all familiar with as well. Propensity score matching uses a logistic regression model. And you do have to make sure that you are modeling terms in the right way. So because the logistic model is a nonlinear model, sometimes if we put something in the model like age doesn't have a linear effect with this sigmoidal shaped curve. And so it would be better to put age in as deciles or, 10-year age brackets or something like that. Nearest neighbor matching is another one. Now, these are the inverse probability weighting. What it does is it gives you a less weight for your observation if you've got missing data. So the extent of missing data, you get a lower score. Augmented inverse probability weighting is another technique, and inverse probability weighted regression adjustments another technique. I'll talk about them in just a second. And so the fundamental problem when we're trying to observe something in an observational data set is that we only observe data on one of the potential outcomes in each person. So instead of assuming that the treatment's randomly assigned, we assume that after we condition on the covariates, the treatment is as good as random. And that's called the conditional mean independent assumption. And so really we're saying after we make this adjustment to balance the covariates across the groups, the treatment is as good as random. And by treatment, I just mean whatever treatment could be, a different one endoscope versus another endoscope, or it could be studying treatment with drug A versus drug B, things like that. So let's think of this example. How much is baby birth weight reduced if the mother smokes in pregnancy? And this is something where we wouldn't be able to do it in a clinical trial, because the IRB would say, no, you cannot do that. So these are some of the models we can use. We can use an outcome-only model where we just adjust for other terms. We can use a treatment-only model where that's the inverse probability weighting, or we can have a different model for the outcome and the treatment. That's an augmented inverse probability weighting. We can also do that with the inverse probability weighted regression adjustment. If we use a non-parametric adjustment, that's the nearest neighbor matching, and that works on an outcome, and treatment is a propensity score matching. So the interesting thing about these two is that they have a double robust property. So they're still good if you misspecify one of the models. And I'm going to look at those to explain what it means. So if we were looking at this model for our, we wanted to know what was the average difference in weight if a mother smoked during pregnancy. And I've used a data set which I can send around to everybody to have a look at. It's from the Journal of Economics, I think. So this is our model. It's a regression adjustment. Our outcome variable is birth weight, and the things that we're putting in the model are whether the mother is married, how many prenatal assessments they've had, if it's the first baby, the mother's education, highest education level, and whether the mother smokes by pregnancy, during pregnancy. And so it tells us that we're using a regression adjustment. It's a linear model. And the mean birth weight for a non-smoker would be 3,402 grams. If the mother smoked, then the mean birth weight would be 231 grams less. So that's with the just regression adjustment. So now let's look at one of the double robust ones where we have to specify an outcome model and a treatment model. So the treatment model is things that might potentially affect the mother's propensity to smoke, and the outcome model is what factors might affect the birth weight. And I've just put the same things in, but this is one of the double robust ones. It tells us we're using an inverse probability weighted regression adjustment. The outcome model is linear because birth weight's a linear model. The treatment model is logistic because whether the mother smokes or not is a binary variable. And we get pretty much the same results. So when you work up this kind of model, you need to decide, what are the factors based on my expert knowledge of the topic that are going to affect either the patient's assignment to the treatment. And so if it's something like, cholesterol, if the cholesterol level's not high, maybe they're going to start on a different statin. The potency of the statin might be different if you're trying to compare outcomes between statin groups. So instead of 230 grams less, we see it's 227 grams less, and the predicted weight was approximately the same. And then this is just a plot of the overlap between the variables after the adjustment, which looks pretty good. So we don't see any substantial imbalance between the groups after the adjustment. Now, this is exactly the same thing done with a propensity score match. And all I've done here, so the outcome variable is birth weight. These are the things that go in the model, the maternal smoking, whether the mother's married. So here I put maternal age in as well, whether it's the first baby and the mother's maternal education. And I specified that the match should only happen if the distance between the propensity scores is 0.1 or less. So it tells us that the estimate is a propensity score match. The outcome model is a matching model, treatment model, it's a logistic model, and the mean difference between the smoking and the non-smoking group is 203 grams, which is not exactly the same, but it's in the same ballpark. And we see, again, the treatment, the overlap plot looks pretty good. Seems to be a bit more discrepancy here in this region, but otherwise they look quite comparable. So stepped wedge designs is the last thing I'm going to talk about. So step wedge designs are kind of a cluster randomized trial, but each site or each unit serves as their own control. It could be a ward in a hospital, or it could be a whole hospital, or it could be a neighborhood. The only thing that's randomized is the timing of the crossover. And you collect observations on each unit at the same time. Why might you do a trial like this? Well, there could be logistic or financial reasons. You might want to evaluate some new program to see how it works. And you might want to evaluate it while accounting for the time on the intervention or some sort of seasonal effect. So this is what it would typically look like. So if we had, okay, so this is saying 90 randomized sites. So we probably wouldn't be doing a trial with 90 randomized sites, but what you do is in this period, so you're collecting outcomes all the time, over these weeks. And the intervention in this cluster is implemented here. Then you have a little transition period for the site to be able to make sure that they understand all the procedures, and then you start collecting outcome data afterwards. And this happens to every site. So you're getting a pre and post observations on each site that can give you very strong evidence. As an example, there was this trial that was published in one of the BMJ journals, I think Quality Assurance, and they had some complex series of interventions to reduce the infection rate in central venous catheters. And this basically showed us that, like, the effect of the intervention. So we see that by the time the fourth quarter in 2010, there was quite a reduction in the infection rate, and the confidence intervals are very tight. And the CVC utilization ratio didn't appreciably change over that time period. So again, it's giving us nice, strong evidence of the effect of the intervention. Yeah, so look, really, I just wanted to introduce you to some of these designs and encourage, groups from different specialties to think about what data they've got and what questions they might be able to give their fellows and their staff to answer, because there's a lot of things that we could do. And I think if we've got a lot of data that in our observational databases, then we're going to be able to get some good estimates of effect after adjusting for different things. And I'd also just encourage people to look on the Equator website for reporting guidelines about any trial designs. There's a very good one about the stepped wedge design. The other studies could just be done with a Strode reporting guideline for observational studies. So is anybody thought we can just open up for questions now? I'll send these slides around, and I've also got some good summary articles about some of the designs that I'll forward to Kun A, and she'll be able to email you.
Thank you very much, Ajahn Steve. Are there any questions? If you have any questions, you can unmute your microphone and ask it right away, or you can type it in the chat box. Ajahn Kwansiri, do you have a question?
Yes. Hello, can you hear me?
Could you speak louder, please?
Can you hear me?
Yes, yes.
Okay, wonderful lecture. Thank you so much to open new world of quasi-experimental study. I have two questions. The first question is the last slide, Equator website. So for quasi-experimental study, what is the keyword of the key reporting guideline? I know consort, Prisma for systematic review, but I'm not sure for quasi-experimental study if we wanna publish in a high rank tier 1 Q1. Maybe we have to know about the guideline for quasi-experimental study.
Yeah, so look, if I would start, if it's quasi-experimental, it's observational. So I would start with the observational guidelines Strobe, but then I would put in the technique that you want to use. So I think this, like if you're using interrupted time series, just type it into the search box on the Equator network, and it will show you the guidelines. If you're using cluster randomized trial, just type cluster randomized or stepped wedge design, or if you're using difference in differences, if there's nothing comes up for that specific term. So I think there is one for interrupted time series, there is one for stepped wedge, but if nothing comes up, then I think you can be confident in using the strobe guidelines.
Strobe guideline, right? The second one.
Yeah.
Okay, got
and there's
it.
lots of strobe extension guidelines. There's so many reporting guidelines, I can't keep them all in my mind. And they're publishing new ones all the time. I think there's probably too many now, but it's good to check just to make sure that your publication's robust.
Okay. And the second question may be some stupid. I'm not sure, but I didn't understand. Well, I try to understand the difference between the each method you say. Would you please tell me some keyword of the benefit or pro or con of each method? I wish to see the table, like the difference between interrupt time series regression, step wedge design, different in different.
Well, some of them are quite similar, and you could use this, like the same intervention to do different things. So if you're looking for trend in something happening, interrupted time series is a good thing to do. If you want to look at something like an outcome, so what I want to look at now is I want to look at the timing of starting antiretroviral treatment on the probability of somebody being virally suppressed. So if they start quite soon after an HIV diagnosis, they started on ART within 14 days, do they have a higher probability of being virologically suppressed after a year, and a higher probability of being in follow-up? So for that, I'd use a regression discontinuity design.
Okay.
It's a huge area that we're trying to cover, but there's a really good article from Annual Reviews in Medicine that I'm also going to send, and that gives you some good examples and some good summary tables.
Okay, thank you so much.
Thank you, Ajahn Khwansiri. There are some questions in the chat box, Ajahn Steve. The first is from Ajahn Chanat. He asked whether some of your example models are very similar to analytical study. Could you explain more in detail how we can differentiate between these two types of design?
Right, you're absolutely correct. They are very, very similar. The only difference is in the experimental design, the researcher is manipulating the outcome. Oh, sorry, manipulating the intervention, where in the then we want to try and make the characteristics adjust for the balance of characteristics across the group. So it's similar to if it's a randomized study, where we would expect all the characteristics to be balanced. Does that make sense, Ajahn Chanat?
Ajahn Chanat, okay.
Yes, thank you.
Yeah, so I think the advantage of, like, say, for example, we want to, I'm thinking of the study at HIVNAT, if we want to know what's the impact on, so we just collect routine data all the time on our patients ever since they are enrolled. So if we want to know, well, what does the, what's the average change in creatinine clearance after a patient started on tenofovir-based regimen? So we've got 2,000 patients in the database that in our outpatient database, we can pick out the patients by their tenofovir, like by whether they're on tenofovir or another drug. And then we can use some of those matching techniques to look at the change in creatinine clearance.
Yes, but the problem is the doctor who gives or decide the treatment for the patients must be in the team of the investigator at the beginning.
Not necessarily.
So you mean it can be what we do it routinely or something like that, Ajahn Steve?
I mean, you have to think through what the impact could be. So if it's, some doctors might have a preference for one drug, other doctors might have a preference for the other drug. But then because if for that kind of study, we'd be using matching techniques. So we'd be adjusting, we'd have a treatment model and an outcome model. So if you really thought that that was important, you could put the physician into the model, into the treatment model, that they'd selected that. But I think they're probably selecting based on some other ideas that they have about which patients are going to benefit. So probably adjusting for important prognostic characteristics to make sure that balance between the groups is going to be just as good as adjusting for the physician. But you can check you can check the models and you can check the balance. Like I said, all of the models have assumptions and things that we need to check.
So for checking the balance, we just view it by eye, or there are any tests for this?
Yeah, so there's different tests for lots of the techniques. I just showed you that that balancing one because it's easy just to estimate, just to see if you think it's a good overlap or not. And normally you'd compare before and after. So I only showed the after plots. So if you look at the plots before and after, then that makes you feel much better because you see that there's been a complete kind of integration if you've done a good match.
Okay, thank you. There are two questions from Ajahn Kerr. The first is, in the quasi-experimental design, are there any tests or methods to evaluate that the result of the study represent the causal effect? Ajahn Kerr, would you like to speak or okay, Ajahn Steve, do you understand the question?
I'm just reading it again.
In the quasi-experimental design, are there any tests or methods to evaluate the result of the study that the result of the study represent the causal effect?
So, I mean, it has to be biologically plausible what you're trying to do. So like you wouldn't be exploring some effect that you didn't have some reason for expecting that there would be effect. So I think that's kind of, and that's when I said it's really important to have a study team who understands the area well, because you need to know what are the potential confounders, what are the things you need to adjust for, what are the considerations that you've got to take into account. So if I was doing some study that wasn't about infectious diseases, I'd have to work really, really closely with the physicians from the area so that I really understood well what they were trying to do. Otherwise, we might get the wrong answer. And of course, if the answer doesn't make sense at all, then you have to think about what's gone wrong.
Okay.
Okay, and
but I think they're useful techniques.
okay. Another question. Would you like to ask him directly, Ajahn Kerr?
Yeah. So another question, like, in some observational study, that we have many clusters, then we have to adjust for the cluster effect. But then in the stepwise trial that mimic the cluster randomization trial, since all of the cluster have their own control, so do we still have to adjust for the cluster effect?
Yes. There's some advantages on, there's an increase in power, but there's I can't remember exactly, but there's some advantages to the cluster randomized trial. So the example, did I tell you about the example that we were going to use? We were going to do a cluster randomized trial on nicotine replacement therapy. So when patients would come in, we had some wards where there was a lot of patients that came in, they were smoking, they'd go into the stairwell and smoke cigarettes. So this was about 15 years ago. And we were going to do a cluster randomized trial so that the patients would be offered nicotine replacement patches while they were in hospital. Of course, they weren't allowed to smoke in the hospital. And then we were going to look and see how many of them had maintained not smoking after they finished, after they were discharged 3 months later. And we had a few different hospitals. We were going to randomize. We decided not to do it by ward in the end because there'd be some crossover effect of nurses and working in different wards. So we decided to do different wards at different hospitals. But yeah, it was an interesting study design, but we didn't get funded, so it didn't go ahead.
So in this kind of study, so the patient characteristic or the population characteristic should be kind of like similar in different hospital, right?
Well, it probably will be because you're doing an intervention on some particular area. So the people who are going to be affected by that disease will be similar. But because it's done in a real world setting and it's using it's not making strict inclusion criteria, it's going to have internal validity and external validity. So the results are really going to inform real world practice. So that's another very good advantage.
Thank you.
There's another last question, I guess, from Ajahn Pramon. So Ajahn Pramon, am I saying your name right? Would you like to ask Ajahn Steve directly? Because your question is very long.
Okay, thank you. Can you hear me?
I can, Cup.
Yes. So we have like a different techniques that you present today, and I review a little bit about different. It seems like the key point is about the interaction terms between the intervention and time. Is that the correct point that we can justify about the effect of your intervention? Because you know that the quasi, we also got like the comments about the lack of randomization, and we try to use the kind of technique to answer the question about the intervention. Is that correct from what I understand?
Yes, that is correct. I think it's also really important when you're doing difference in differences studies, you can also difference in differences studies. So it can be complex designs, but I think it's very important to show a graph just to help people understand what's going on. The slope before the intervention, then when the intervention happens, and then what happens after the intervention. And if you're doing something that's a non-linear model, then you just have to, if it's a binary outcome, you just take do a logit transformation so that it's clear to what's happening in the diagram, so people can see the parallel effects.
Okay. And it's linked to another question about if you measure the outcome so many times, and you know that we also have many techniques to use to analyze the data, like a linear mixed model, also the GEs and something like that. do we need to apply the different into this, or we don't need to apply to this? Because it seems like from the slide that you show, it's like only 2 times or 3 times, I forgot.
Yeah, so look, that's a very important point. And if you're doing something where you've got repeated measurements, you know, like multiple observations, then you do need to have a mixed model. You can't just do it by a simple, so the diagram I showed was kind of like the change at the first part and the change at the second part. So there was really only 2 time points. So a normal regression model. But if you're going to do something where there's multiple observations on the patients, and you need to model that clustering effect. And you could do it with a GEE or a mixed model, whatever you feel comfortable with using.
So if I use GEs or the linear mixed model, maybe I don't need to check for the different, right? Because we have like a random effect already to concern about the variation.
Yeah, correct.
Okay, thank you so much.
Indeed.
Since we come to the end of this hour, I think Ajahn Kwansiri has another question. Would you mind to answer this question, Ajahn Steve?
One last question. Share your experience. What is the most common problem you encounter when you be a consultant about quasi-experimental study?
Okay, so mostly no one ever asks me about quasi-experimental studies, but I do suggest them to people sometimes. What I used them mostly for was in drug utilization studies, where we had some intervention. We were trying to change prescribing habits. When I was working at the National Prescribing Service, that was mostly what we used them for. And there's a lot of literature about that. But there's also, you know, literature about, there's a great, there's so many different quasi-experimental designs. It really depends on, the problems are going to differ based on what one you're using. But usually you've got data there, and it's just a question of deciding, well, what's the right kind of study that I'm going to use to interrogate my data to get the answer that I'm interested in.
Okay, thank you so much.
Okay, so I think questions are, there are no more questions right now. So on behalf of Research Affairs, I'd like to thank Professor Steve Kerr for your broadening our vision in the new design of study. So I think we can select this new method for our research design in the near future. If anybody are going to do research like this. So I'd like to thank you and thank all the audience for your interest in our activities at the Research Affairs. And I think that this is the last activity for this executive committee. Thank you for all your supports in the past 6 years. Thank you very much. And thank you very much, Ajahn Steve ค่ะ and also the team ค่ะ ขอบคุณค่ะ ขอบคุณมากค่ะ ค่ะ สวัสดีค่ะ